Welcome to my channel. Subscribe or like if you like. Today we will explain the active principle misoprostol, cytotec. We will talk about its side effects, its dosage, contraindications, warnings, its mechanism of action, pregnancy, breastfeeding and much more. What is misoprostol? Misoprostol is a semi-synthetic analog of prostaglandin E1, PGE1, used for the prevention and treatment of gastric and duodenal ulcers. It is also indicated for labor induction, abortion in certain countries, and treatment of rejection in transplant recipients. Here we will discuss the use of misoprostol in gynecology. What is misoprostol used for? Misoprostol, in the form of a vaginal insert, with a controlled release mechanism, is indicated for induction of labor in women with or near-term pregnancy. It is also used, in some countries, for medical abortions and specifically for induction of labor and, in combination with other drugs such as mifepristone, for voluntary termination of pregnancy. The trade name of misoprostol is cytotec. Mechanism of action of misoprostol. It induces contraction of the uterine muscles, acts as a blood vessel dilating agent and as a mild bronchodilator on the bronchial smooth muscle fiber. It also acts on the gastrointestinal tract by inhibiting acid secretion, acting directly on gastric parietal cells, decreasing pepsin production, stimulating duodenal bicarbonate secretion and increasing gastric mucus production. Therapeutic indications of misoprostol. Cervical maturation and induction of labor at term, especially in cases of immature cervix as long as there are no fetal or maternal contraindications, 25 micrograms. Dilation of the cervix of the non-pregnant uterus prior to hysteroscopy or other gynecological procedures requiring access to the uterine cavity, 200 micrograms. Vaginal release system 200 micrograms, induction of labor in women with an unfavorable cervix, from the 36th week of pregnancy, where induction is clinically indicated. Side effects and adverse reactions of misoprostol, in gynecology. Vaginal tablets, nausea, vomiting, diarrhea and abdominal pain. Vaginal release system, fetal heart rate disorder, abnormal delivery affecting the fetus, meconium in the amniotic fluid, abnormal uterine contractions. Dosage of misoprostol, in gynecology. Vaginal route. Vaginal tablets. Cervical maturation and induction of labor at term, especially in cases of immature cervix as long as there are no fetal or maternal contraindications, 25 micrograms at 4 to 6 hour intervals, up to a maximum of 100 to 150 micrograms. Dilatation of the cervix of non-pregnant uterus prior to hysteroscopy or other gynecological procedures requiring access to the uterine cavity, 400 micrograms 2 to 8 hours before, in uteruses with no history of previous C-section or uterine scarring, and 2 to 4 hours before, in uteruses with the history of previous C-section or uterine scarring. Vaginal release system. Induction of labor in women with an unfavorable cervix, from the 36th week of pregnancy, where induction is clinically indicated, controlled release system that releases misoprostol at a rate of approximately 7 micrograms every hour for 24 hours. Maximum dose of a vaginal delivery system, 200 micrograms. Mode of administration of misoprostol. Vaginal delivery system, administered by staff with obstetrics expertise in a hospital where means are available to allow continuous fetal and uterine monitoring. The condition of the cervix will be carefully evaluated before using misoprostol. After insertion, uterine activity and fetal condition will be monitored regularly. Contraindications of misoprostol. Hypersensitivity to misoprostol, to prostaglandins, when oxytocic drugs are contraindicated or prolonged uterine contractions are considered inappropriate. Cervical ripening and induction of term labor. History of cesarean section or major uterine surgery, cephalopelvic disproportion, clinical suspicion or evidence of pre-existing fetal distress, history of difficult and or traumatic delivery, multiparous with 6 or more previous term pregnancies, transverse fetal situations, obstetric emergencies when the risk-benefit ratio for both fetus and mother warrants surgery, multiple pregnancies, unexplained vaginal discharge and/or irregular uterine bleeding during the current pregnancy, patients in whom vaginal delivery is not indicated, such as with placenta previa or active genital herpes, concomitants of oxytocin and other stimulants of uterine contractions, risk factors for amniotic fluid embolism, severe preeclampsia or eclampsia, induction of labor in women with unfavorable cervix, from the 36th week of pregnancy. When labor has begun, when there is suspicion or evidence of fetal distress prior to induction, for example unsuccessful or failed stress test, meconium staining of amniotic fluid or diagnosis or history of non-reassuring fetal condition, when there is suspicion or evidence of uterine scarring resulting from previous uterine or cervical surgery, for example cesarean delivery, when there is uterine abnormality, for example bicornate uterus, when there is placenta previa or vaginal bleeding of unknown cause after 24 weeks of gestation in the present pregnancy, when there is poor fetal position, when there are signs and symptoms of chorioamnionitis, unless appropriate prior treatment has been instituted, before the 36th week of gestation. Warnings and precautions with misoprostol. Epilepsy or history of epilepsy, renal or hepatic disease, cardiovascular disease, hypotension, history of cesarean section or major uterine surgery, with hemostatic disorders accompanied by hypocoagulability or with anemia, rupture of chorioamnion membranes, chorioamnionitis, infection of the placenta membranes and amniotic fluid, hydatidiform mole and intrauterine fetal death not recommended in renal failure, liver failure, malnutrition. Increased risk of postpartum disseminated intravascular coagulation in patients who have been induced to give birth by a physiological or pharmacological method. Vaginal release system. Misoprostol may cause excessive uterine tachysystole that may not respond to treatment with tocolytics. Monitor closely to ensure that the vaginal delivery system is removed immediately at the start of labor or if uterine contractions are prolonged or excessive or if there is a clinical complication in the mother or baby. Misoprostol is used for induction of labor at term, at low doses for a short period of time. When used at this time of pregnancy there is no risk of fetal malformation. However, it should not be used at any other time in pregnancy. A threefold increased risk of fetal malformations, including Mobius syndrome, amniotic band syndrome, and central nervous system abnormalities, has already been reported in pregnancies exposed to misoprostol during the first trimester. Liver failure and misoprostol. Caution in moderate or severe liver failure. Increased AUC, Cmax and T-half have been observed, but do not appear to proceed to pathologic readjustment. Renal failure and misoprostol. Caution in moderate or severe renal failure. Increased AUC, Cmax and T-half have been observed, but do not seem to proceed to a pathologic readjustment. Interactions with misoprostol. Powerful effect of oxytocin. Inhibition of the anticoagulant effect of acenocomerol. Potentiation of toxicity at a neurological level with phenylbutazone, naproxen and abdominal pain or diarrhea, diclofenac, indomethacin. Increases frequency and intensity of diarrhea with antacids. Administration of laxatives, intense diarrhea. Pregnancy and misoprostol, in gynecology. Misoprostol, at high doses, produces an increase in congenital anomalies in rats and rabbits, including anomalies in the upper and lower extremities and in the CNS, with the most sensitive period being between the first and second month of pregnancy. Misoprostol has been observed to have an embryotoxic effect in rats and rabbits, and any dose that produces a sustained increase in uterine tone may endanger the embryo or fetus. More than 35 types of abnormalities have been described in children exposed to misoprostol during the first trimester of pregnancy, which can be categorized by anatomical groups. The most frequently described defects were those of the lower extremities and occurred in 4/5 of all cases. More than half of the cases had central nervous system abnormalities, while 2/5 and 1/4 had abnormalities in the upper extremities and skeletal system, respectively. 2/5 of the cases had other abnormalities such as defects of the genitals, eyes, or palate. Effects have also been reported on children of mothers who ingested misoprostol in a failed attempt to induce an abortion. The most common effects include Mobius syndrome, congenital facial paralysis, and limb defects. Still, the absolute risk of this syndrome is relatively low among women exposed to misoprostol during the first trimester of pregnancy. Breastfeeding and misoprostol. It is excreted in breast milk, but its concentration is negligible within 5 hours of administration. Effects on the ability to drive by taking misoprostol. Not relevant.